Is it okay now? Yeah. At the outset, let me thank Dr. Lawrence for having invited me to take part in this academic session. Now, I know it's very difficult to keep you people awake after a heavy meal, and Lawrence has made sure that all of you guys are well fed. So anyway, let me go on to my task and of talking something about heart failure. The though this is the major epidemic of the country, and where cardiologists probably are going to be involved in a much bigger area, but I think this is a topic which is of equal importance to the physicians. Now, if you look at the scenario of the journey of heart failure, right from I think the physician has an important role to not just diagnose heart failure right from the time where there is no heart failure. For example, you have conditions which can be a stage A, where you could identify the risk factors like diabetes, high blood pressure, and then once the heart failure sets in, it's a journey where it's a continuum, where the patient starts deteriorating if not properly attended to, and over a period of time they get into the sequence of worsening heart failure, and finally an advanced stage where perhaps there's nothing else to do except for a transplant or a mechanical device. So I think it's important for the physician to really identify this and look at this at a much more uh, uh, detailed manner. Now, I was fortunate enough to run a registry in this country where we studied more than 10,000 patients. And I must tell you that if you look at the heart failure today, the commonest is ischemic heart disease. So I think when you just see a patient, 90% of these heart failure patients have an abnormal ECG. So the moment you see somebody with breathlessness, I think the way to work up is just to look for an ischemic heart disease, because this is an eminently treatable condition where even if you think of the definitive therapy for heart failure, you need to sort it out. But unfortunately, these patients are not really worked up properly. That's why I thought that this should be the first thing that we need to attend to. Even in a country like United States, if you were looking at heart failure, only about 30% of them they get a coronary angiogram done. So this is very sad, because this is a treatable cause, and if you are able to have a patient who has who could be revascularized either by an angioplasty or surgery or even a good medical therapy, that's the first job. And of course, as physicians, you will be confronted with the problem of hypertension. This is no small deal today. I think about 35%, one third of our population. If you look at the latest Lancet endocrinology publication to 2003, you find that hypertension is close to the prevalence is about 30%. And of course, chronic kidney disease on the rise. You have an aging population, you're treating them well, they're surviving long. And of course, look for sometimes, reversible factors like, stress cardiomyopathy or thyroid. This is often neglected. So I think these workups are very important. I thought this should be the upfront thing before you start treating. Anemia, the very common thing. Arrhythmia. Sometimes, patients come to you with heart failure. You find we had a lengthy session on atrial fibrillation. These people are sometimes going in for paroxysmal atrial fibrillation. And if this is not recognized and treated, the heart failure improves. And of course, nutritional deficiencies, and of course, iron deficiency, which is a very major factor even in heart failure. So now, coming back to the definitive therapy, once you are diagnosed heart failure, I think today we know that there are foundational therapies. If you don't put them on any therapy, you find that 2 years, 35% of them they die. Whereas if you start them, we call the AB. I would rather say it as A, B, C, D, in the sense that A is an ACE or ARB, B is a beta blocker, C is the Mindlo receptor antagonist, D is the SGL2 inhibitor. RNA would replace it's either A is ARB or RNA, which I'll come to a little later on. And of course, the D is the SGL2 inhibitor, the DAPA being the most cheaper drug available in the country. So you keep on adding this, you find the relative risk of the problems starts coming down, and then everything adds on, and so much so the 5-year mortality would definitely be less. The number needed to treat in this is just 4 out of 1 to get the desired reduction in therapy. So I think today in 2023 we are fairly clear. These are the pillars. RAS inhibitors, which I'm sure most of the patients today, most of the physicians would then start them on an ACE inhibitor. But I think those days are gone. Today RNA would be the first choice, beta blocker, MRA. These are the 4 pillars. And of course, the most important thing when you have a heart failure, they should also be decongested, because loop diuretic is important, not too much of a dosage, but at the right dosage. Let me just take you through a case scenario. This is a guy who had a young fellow, 44-year-old. No, I think seeing is believing. This patient had a old inferior wall myocardial infarction. We studied him by an angiogram, as I had mentioned earlier. rule out ischemic heart disease, but his arteries were fairly patent. But despite that, his LV had, once the insult happened, his LV deteriorated. He had heart failure. And in fact, so symptomatic. If you look at the ECG, the heart dilated, hardly contracting there, and you see the significant amount of mitral regurgitation. In fact, he was so symptomatic, getting into the hospital. That is the time when we initiated him on this so-called 4 therapies, A, B, C, D. And initially we thought that this might end up in a transplant, the way he was going and all that. But you could see the difference over a period of time, remarkably improved. In 2021, within 3 years, he's back to about class 2 and back to his job. So I think that's the important message I want to tell you. If you put them on this appropriate therapy, you can at least improve their quality of life, halt the progression of the disease. That is what we are looking for in heart failure. And this is what we call as a guideline directed medical therapy, the 4 such agents. And you must understand that if you what you see on the right hand, the blue is what you see in green here is the guideline directed medical therapy. The moment you put them on guideline directed therapy, you find that all cause hospital, not just heart failure or cardiac, comes down. The cardiac also comes down. Not only that, the quality of life improves and the recurrent hospitalization also comes down. So I think that's the importance of really putting them to all these 4 drugs. And not only that, this is one of the most quoted articles today, Vadaganathan's article, where if you put them on all these 4 standard therapies, for example, a 54-year-old guy, you put them on that, you see the survival benefit is close to about 6.3. He gains another 6.3 years in life, which is a tremendous thing. Not only that, an event-free, a recurrent hospital event-free is even more, 8.3 years. So I think it's important to understand that somebody develops heart failure, it is the onus on the physician to put them on this 4 pillars of therapy to have a fairly decent quality of life, and that too, again, and also in terms of reduction of mortality. We just conducted this survey which I was talking to you about it, and then we actually did this in 2 phases, 2018 to 19. This is the pre-COVID times. This is about 5,269. Subsequently, we had another 5,000, total 10,000 patient data all over the country. In fact, we had Kupaswamy Naidu as one of the centers from Coimbatore. And we found that when you look at in India, what you find is, despite all this, even these are all tertiary care hospitals managed by cardiologists. You see that the RNE is a dismal 2.6%. The ACE ARB is about 42. Beta blocker is slightly on the higher side. And of course, they are all on a fairly large dose of diuretic. But the point I wanted to convey is that only 1/4 of our patients, even in the best centers in India, were only on this therapy. I think this is something which we need to understand. We still have to go a fairly longer duration to see that these are properly managed. And why is it so? When you look at the meaningful benefits of this foundation therapy, it is about, again, the physician should understand that somebody has heart failure, start them on this as early as possible, because the benefits start coming with an ACE as early as 14 days, beta blocker 28 days, mineral receptor antagonist 30 days. There's no point trying to put these patients beyond this. ARNI, even the first 30 days. SGLT2 inhibitors again. So within the first month, if you're able to get these patients on board, this has got a favorable effect in terms of outcomes. So because of all this, the American College of Cardiology, and they came out with the expert consensus pathway, where the question is how to switch on, how to achieve the optimal therapy, and that's exactly what I'm going to tell you in the next 10 minutes. So the major recommendation, I talked about the baseline therapy, but I think the major recommendation, the sea change that you should understand today is, somebody has heart failure, don't wait them, start them putting on ACE, ARB, and then try to switch on. ARNI becomes the first line, because today we know we have abundant data. ARNI is a sacubitril valsartan angiotensin receptor blocker combination. So if you put them on this, this has a major achievement, and that's become the first line. Secondly, across somebody has heart failure, how do you diagnose heart failure? It's mostly a clinical diagnosis. And today, if you want to have, you don't need an echo if you have to think in terms of an SGLT2 inhibitor. SGLT2 inhibitor, your molecule, which, it could be any glyphosins, particularly DAPA or EMPA, across any spectrum of ejection fraction. The moment you have a heart failure, it is beneficial, whether it's a reduced ejection fraction or a preserved ejection fraction. And of course, the third important message is, you start them on low dose of everything at the same time. Now, this is all based on data, because the RNA, why I said start them initially, because the paradigm study, which is a study which compared this with an ACE inhibitor, enalapril, showed a 20% reduction. And today, I think we were all, when this medicine, the Vimada, got introduced, we were all scared to use this costly drug. But I tell you, the moment we started embracing this, the patient outcomes started looking better. And so much so, there was a 4.6% reduction in primary outcome. Out of 27 patients, number needed to treat was 1 in 27 to have the desired outcome. 20% decrease in sudden cardiac death. In fact, the only drug in heart failure which has shown a efficacy in sudden cardiac death is the beta blocker, but 20% decrease if you put them on ARNI. Of course, the physicians might say there is a symptomatic hypotension, but this could be overcome. There are some tips of doing it, but there is no worsening of renal function. This was a worry for some of the physicians, and these are things which are really cleared. And if you were to compare with the ACE or ARB, which is what the standard therapy was once upon a time, you find that the significant reduction comes with ARNI. So today, without doubt, I think the first drug that you need to put the patient on in heart failure is an ARNI or the angiotensin receptor blocker, sacubitril statin combination. And the initial recommended, this is all mentioned for chronic heart failure. But today we know, even in hospitalized patients, if you start, one of the measures, how do you diagnose heart failure apart from the clinical diagnosis? It's a biomarker called NT-proBNP. I keep telling people, these physicians, that this is just like your troponin T. Today you are so much comfortable. Somebody has chest pain, troponin is positive, you know it's an acute coronary syndrome. Similarly, if it is more than 125, this is high. So they looked at the NT-proBNP and they found that if you put these patients on this ARNI, the NT-proBNP comes down, telling you that this is very important. And not only that, very important message is that this is one drug which has shown there are no drugs which have shown such efficacy in terms of improving the LV function. Look at this, 9.4% improvement in the LV function in 12 months. And not only that, out of this group, 1/4 had an EF improvement as high as 13%. Again, proving the point that this is the way to go about. So to sum it up, ARNI, we know that there is an improvement in LV function. So this is the drug to go, and it could be used in de novo. Don't wait for an ACE or ARB. Start them straight away, even on ACE, ARB naive patients. And it lowers the NT-proBNP levels. And of course, even in low doses, I mean, in India, we have also seen that the target dose is 200 milligram BID. But today, we also know that even at the smallest of dosages, this is effective because these are drugs which will actually prevent the worsening. So once you have a heart failure, you must understand that the moment they get admitted, there is the trajectory is that they deteriorate. You might stabilize them, but over a period of time, they deteriorate, enter into the early post-discharge phase and follow up. They start deteriorating, and one should actually start them as early as possible to have the benefit. So the management of heart failure is that start this therapy early, hospitalize patients, because this is a very important message which I wanted to convey. The best time to start this is when the patients are admitted in the hospital, not when they come to the OPD. Because they always tend to believe the doctor during hospital. They don't want another hospitalization. And of course, the follow-up is based on the clinical trajectory. Now, is there any data to suggest this? We also know that when you have something started in the hospital, for example, the beta blocker, if you start them in the hospital, 90% of them are adherent to that. This is a famous quote by Fonoro in 2007. Similarly, if the ACE inhibitor start in the hospital, 71% would be adherent, whereas only about 19% if you start them on OP, it will be adherent. So I think start them early as far as the hospitalization. So the tips are, the major worry for the physician is in terms of hypotension. So the tips actually initiate during hospitalization the moment you take them off a IV diuretic. Secondly, you can use a low dose so that you don't have the hypotension. Avoid dehydration. This patient, hydrate them very well. And the third important, if you have a borderline BP, you're worried, reduce the dosage of diuretics, but keep the ARNIs going. And again, titrate to the guideline dosage at home. There have been studies which have shown that this is found to be effective. And direct to ARNI approach, don't start on an ARB or ACE, start them straight away. So these are the ways to go about to start them on ARNI. The second important drug is the beta blocker. When do you start them? Initiation is as early as possible. The moment they are decongested, don't start them in a patient with acute LVF, but the moment they are stable, same time as an ARNI, you could use it. And the heart rate, today we know that the most important drug which really prevents outcomes or deaths is the beta blocker. And the higher the dosage of beta blocker, the better. But then you need to take your time to start them on a small dose and initially, and then keep on increasing them. But the important thing is you gradually uptitrate over a period of 2 weeks and initiate it when these patients are less congested or dry. And of course, the only problem is that no beta blocker if the resting heart rate is low. And avoid carvedilol. The most important thing, though many people, I'm sure a lot of cardiologists actually believe in this drug, but the problem when you combine carvedilol with ARNI is the hypotension. So if you have a hypotension, borderline blood pressure, the drug you could depend on is probably bisoprolol. The third important drug is a C melanoreceptor. Again, whether question is whether before or RNA, but this is a safe drug. You only need to look at the renal function, the potassium. But believe this is not for a diuretic effect. It is for actually to prevent the LV from enlarging, to prevent the remodeling. Efficacy again when started within 7 days, but beyond 28 days, it may not be effective. So I think all these drugs should be started as early as possible. And of course, you tend to see hyperkalemia. Today, as per the guideline, even if you see hyperkalemia, there are agents like the patrimir which are useful in trying to sort out this hyperkalemia. And of course, the fourth drug in the group is the SGLT inhibitor. I don't have to go this into detail. The DAPA-HF and the Emperor have really shown there's clearly about 20% reduction in the hospitalization mortality. So these remain the four major pillars of therapy. Along with that, we have a very high resting heart rate. Despite on a beta blocker, you could add ivabradine. And the new drug, which is very promising, Versiguard. In fact, we have all started using this in a much bigger way. When you have a worsening heart failure, is an add-on in the armamentarium heart failure. Digoxin, sometimes recurrent hospitalization, there still is a role. Small dosage, 1.125 milligram. And of course, PUFA and potassium binders are also an addition. Now, when do you start ivabradine? I think there is a tendency for the physician to start this as early, but it should not be done before a beta blocker. If still on beta blocker, the heart rate is more than 70, it's fine. Or up titration when you are not able to increase the beta blocker due to some reasons. Or for example, you have a bronchospasm, you're not able to use a beta blocker, it's a good choice. But 50% of the on target dose ivabradine use is supposed to be beneficial. But a word of caution, shift data subanalysis shows it's not useful in when you have a atrial pace rhythm, chronic atrial fibrillation, and also in unstable situations never use an ivabradine. And also there is also a tendency for ivabradine to produce paroxysmal atrial fibrillation. In fact, it was seen in about 40% of the time in patients even in normal sinus in the trials. But the new drug which I have mentioned is called the Versiguard, which actually is through the signaling the cyclic guanyl cyclase GMP pathway, which acts like a vasodilator. It's almost like a nitrate-like effect. And this not only has an effect on the myocardial system, also got an effect on the vascular function. And this trial actually was terminated very prematurely in about 10 months' time because it gave, even in patients who were getting recurrent hospitalization due to heart failure, there was a 10% reduction in hospitalization. In fact, this is one of my patients post-cabbage where a patient came with very sick on most of the drugs could not be used because his renal function was not very good. He had hyperkalemia. The pressures were not good. The only drug he would tolerate at that point of time on 23rd of January was this. And he made a remarkable improvement. Today he's just class 2. And you see the kind of improvement in the LV function. So this patient was started on this Versiguard 2.5, went to 5. Today is on the dosage of 5 milligram and doing very well. So I think the simplified algorithm is initiate all 4 I just mentioned earlier, A, B, C, D, beta blocker, MRA and DAPA there. So assess the clinical situation. And of course, when you put this patient, you need to reassess the LV function. And there was a time when we thought that the way to go about is by a conventional system, but today that is different. You keep on adding, even at the smallest dosage initially, a beta blocker, SGL2, then of course an RNA and melanoreceptor. And today we also go to, there is a data called the strong heart failure, which is got published in Lancet, where you put them on the small dose, keep on increasing at 2 weeks, and by 6 weeks on the highest possible dosage. You find that the high intensity care, they are all, when they are randomized, they are all on much higher dosage of ARB, beta blocker, and this actually translated to clinical events in terms of reduction of mortality by about 180. And again, this was prematurely terminated. So much so, the ESC today has made this as a guideline, and we are trying to push off. And in fact, there is another trial which has also shown that rapid sequencing on day 2, there is an algorithm there. If you do that, the outcomes are better in terms of reduction of mortality as well as recurrent hospitalization. But despite saying all that, this is a recent publication in the European Heart Journal, which shows that the number of patients on what you see on green is the number of patients on this therapy who are added, and the chance of uptrading is still low even in the Western countries. Maybe because of a variety of reasons. For example, somebody does not have the blood pressure, the physician is reluctant, the heart rate is low, you can't add a beta blocker, chronic kidney disease, the potassium is high, presence of absence of AF. So there are many factors, but I think the key is actually there is a large non-adherence, old age, frailty, hypertension, many reasons. But I think it's important to understand that we need to really push this. So despite all this, the CHAMP registry showed that only 1% of the patients were on therapy. And we also have disparities. For example, if you find that women, patients without health insurance, cost, everything is a big factor in the low middle income countries. So there are a lot of reasons, and other important challenges. Even in this is a recent publication, the evolution heart failure trial from UK, which has shown that even if you put them on that, the best drug, the SGL2 and the ARNI, which I was talking at length, they are not really utilized the way it should be. You see, what is there in green is the dapagliflozin. It's not in a really desired way. There's still a long way to go. So I think we need to go one step further. Maybe there are a few things to look into. For example, the generics may be cheaper. In diabetes patients, I mean, SGLT could be the way. Reduce the therapeutic complexity because polypharmacy is a problem. And of course, a careful medication. More importantly, I think once you started them, please follow them up. It's 2 weeks, titrate the drugs, evaluate the renal function, ventricular function maybe once in 3 to 6 months. More frequent if the patient becomes symptomatic on these drugs. And of course, routine echo to identify candidates for advanced therapies. And of course, if you have the facility, do an NT-proBNP to see how well they are doing. And sometimes you may have to go to the extreme when the patients really keep deteriorating to send them to a specialist and to look at the invasive peer pressure monitoring. So I think the accelerated and personalized therapy, this is a new way to look at things. I mean, this is actually, if you put them in all this, within a short time, 1, 2, what you see here is the weeks, 1, 2, 5 and 4, the sequencing, you find there is a 50% reduction in terms of mortality at the end of 1 year. So I think that's the way to go. So the final message is that heart failure with reduce is a serious and challenging problem. The guideline-directed medical therapy, which I was stressing, is a very improves the quality of life and mortality. Early initiation is the key. All 4 ARNI, SGLT inhibitors have shown remarkable efficacy, and these are the drugs to be used. Follow-up is crucial, identifying poor responders, and newer therapy and interventions are really encouraging. Thank you all for the kind attention.